Principles and Management of Shock. An in-depth question and answer exploration for learners. Welcome to the Everything Surgery podcast. Today we ask 100 essential questions on the management of shock based on the ATLS guidelines. Pause the video when you hear the word answer to attempt answering the question. Let's begin. Fundamentals and Pathophysiology question. What is the definition of shock? Answer. Shock is defined as a state of inadequate tissue perfusion and oxygenation that ultimately leads to cellular dysfunction and death. Question. What is the common final pathway of all types of shock? Answer. The common final pathway is cellular hypoxia and a switch to anaerobic metabolism, which results in the buildup of lactic acid and acidosis. Question. What are the four classic types of shock? Answer. The four classic categories of shock are hypovolemic, cardiogenic, obstructive, and distributive shock. Question. What are the earliest signs of shock? Answer. The earliest signs of shock include an elevated heart rate and the presence of cool, clammy skin, except in the early stages of distributive shock. Question. What are the late signs of shock? Answer. Late signs of shock include low blood pressure, changes in mental status, and the absence of urine production. Notably, a drop in blood pressure is considered a late sign. Question. What is the body's first compensatory mechanism for shock? Answer. The body initially responds to shock through an elevated heart rate to increase cardiac output. Question. What is the second compensatory mechanism? Answer. The second compensatory response is peripheral vasoconstriction, which helps to redirect blood toward vital organs such as the brain and heart. Question. What is the equation for blood pressure? Answer. Blood pressure equals cardiac output multiplied by systemic vascular resistance. Question. What is the equation for cardiac output? Answer. Cardiac output is the product of heart rate and stroke volume. Question. What three factors determine stroke volume? Answer. Stroke volume is determined by preload, contractility, and afterload. Classification and diagnosis question. What is the most common type of shock in the surgical patient? Answer. Hypovolemic shock is the most commonly encountered type of shock among surgical patients, most often as a result of hemorrhage. Question. What are the four classes of hemorrhagic shock? Answer. Hemorrhagic shock is classified as follows. Class I involves less than 15% blood loss. Class II is 15 to 30%. Class III is 30 to 40%. And Class IV is greater than 40% blood loss. Question. What is the typical heart rate in Class II hemorrhagic shock? Answer. In Class II hemorrhagic shock, the heart rate usually exceeds 100 beats per minute. Question. What is the typical blood pressure in Class III hemorrhagic shock? Answer. In Class III hemorrhagic shock, blood pressure decreases and hypotension develops. Question. What is the mental status in Class III shock? Answer. Patients in Class III shock tend to be confused or agitated. Question. What is the urine output in Class III shock? Answer. Urine output in Class III shock is reduced and typically less than 0.5 milliliters per kilogram per hour. Question. What is decompensated shock? Answer. Decompensated shock occurs when the body's compensatory mechanisms, such as an elevated heart rate and vasoconstriction, are no longer sufficient, resulting in severe hypotension. Question. What is the role of serum lactate in shock? Answer. Serum lactate serves as a marker of anaerobic metabolism. An elevated level, greater than 2 millimoles per liter, indicates shock, and monitoring its trend is useful for assessing the adequacy of resuscitation. Question. What is base deficit? Answer. Base deficit is another metabolic marker of acidosis and poor perfusion. A more negative value, such as -6, signifies more severe shock. Question. What is the shock index? Answer. The shock index is calculated as heart rate divided by systolic blood pressure. A value above 0.9 suggests shock, while values above 1.2 indicate significant hypovolemia. Hypovolemic shock question. What are the most common causes of hypovolemic shock? Answer. The most common causes of hypovolemic shock are hemorrhage, including trauma and gastrointestinal bleeding, and fluid losses due to burns, vomiting, or diarrhea. Question. What is the lethal triad of trauma? Answer. The lethal triad of trauma consists of acidosis, hypothermia, and coagulopathy. This vicious cycle can be fatal if not interrupted. Question. What is damage control resuscitation? Answer. Damage control resuscitation is a strategy for managing hemorrhagic shock, involving permissive hypotension, balanced transfusion of blood products, and rapid control of bleeding. Question. What is permissive hypotension? Answer. Permissive hypotension refers to resuscitation to a target systolic blood pressure of 80 to 90 mm of mercury, or sufficient to maintain a palpable radial pulse, until surgical control of bleeding is achieved. This approach helps prevent disruption of blood clots and further bleeding. Question. When is permissive hypotension contraindicated? Answer. Permissive hypotension is contraindicated in patients with traumatic brain injury, as they require a systolic blood pressure above 90 mm of mercury to maintain cerebral perfusion. Question. What is hemostatic resuscitation? Answer. Hemostatic resuscitation involves transfusing blood products in a balanced ratio, typically plasma, platelets, and packed red blood cells in equal proportions, to address coagulopathy and restore hemostasis. Question. Why avoid large volumes of crystalloid in hemorrhagic shock? Answer. Large volumes of crystalloid should be avoided because they can worsen coagulopathy through dilution, increase hypothermia and acidosis, and heighten the risk of reperfusion injury. Question. What is the role of tranexamic acid in trauma? Answer. Tranexamic acid should be administered within 3 hours of injury to reduce mortality from bleeding in patients experiencing shock. Question. What is the first step in managing external hemorrhage? Answer. The initial step in managing external hemorrhage is the application of direct pressure to control bleeding. Question. What is resuscitative endovascular balloon occlusion of the aorta? Answer. Resuscitative endovascular balloon occlusion of the aorta is a temporizing procedure used to control non-compressible truncal hemorrhage by occluding the aorta. Distributive shock. Question. What is the hallmark of distributive shock? Answer. The hallmark of distributive shock is low systemic vascular resistance, which leads to vasodilation and maldistribution of blood flow. Question. What are the three main types of distributive shock? Answer. The three primary types of distributive shock are septic shock, neurogenic shock, and anaphylactic shock. Septic shock. Question. What is the definition of sepsis? Answer. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Question. What is the definition of septic shock? Answer. Septic shock is defined as sepsis with persistent hypotension that requires vasopressors and a serum lactate level greater than 2 millimoles per liter. Question. What is the golden hour of sepsis management? Answer. The golden hour refers to the first hour of care, during which early administration of antibiotics and resuscitation is critical. Question. What are the key components of the Surviving Sepsis Campaign 1-hour bundle? Answer. The 1-hour bundle includes measuring lactate, obtaining blood cultures, administering broad-spectrum antibiotics, and delivering a 30 ml per kilogram crystalloid bolus if the patient is hypotensive or has a lactate level of 4 or higher. Question. What is the first-line vasopressor for septic shock? Answer. Norepinephrine is considered the first-line vasopressor for septic shock. Question. When is vasopressin added? Answer. Vasopressin is added as a second-line agent to support blood pressure and decrease norepinephrine requirements. Question. When should steroids be considered in septic shock? Answer. Steroids should be considered when hemodynamic stability is not achieved with adequate fluid resuscitation and vasopressor therapy. Question. What is the target mean arterial pressure in septic shock? Answer. The target mean arterial pressure in septic shock is greater than 65 mm of mercury. Neurogenic shock. Question. What is the mechanism of neurogenic shock? Answer. Neurogenic shock results from the loss of sympathetic tone following spinal cord injury at the 6th thoracic vertebra or above, causing vasodilation and unopposed vagal tone. Question. What is the classic presentation? Answer. Neurogenic shock classically presents with low blood pressure and a slow heart rate, which contrasts with the elevated heart rate seen in other types of shock. Question. What is the primary treatment? Answer. The primary treatment is vasopressor therapy to counteract vasodilation. Cautious fluid administration may also be considered. Anaphylactic shock. Question. What is the mechanism? Answer. Anaphylactic shock is caused by a severe immune-mediated allergic reaction that triggers widespread vasodilation and leakage of fluid from capillaries. Question. What is the first-line treatment? Answer. The first-line treatment is the intramuscular administration of epinephrine, typically 0.3 to 0.5 milligrams of a 1 in 1,000 solution injected into the mid-outer thigh. Question. What are adjunctive treatments? Answer. Adjunctive therapies include fluid resuscitation, antihistamines, corticosteroids, and medications that open the airways. Cardiogenic shock. Question. what is the primary problem in cardiogenic shock? Answer. The primary problem in cardiogenic shock is failure of the heart to pump effectively, resulting in decreased cardiac output. Question. What are common causes? Answer. Common causes of cardiogenic shock include heart attack, abnormal heart rhythms, cardiac injury, and tamponade. Question. What are the classic findings? Answer. Classic findings are low blood pressure, an elevated heart rate, and evidence of pulmonary edema, such as crackles heard on examination and low oxygen levels. Question. What is a key diagnostic finding on physical exam? Answer. Elevated jugular venous pressure is a key finding on exam. Question. What is the most important diagnostic test? Answer. The most important diagnostic test is an echocardiogram to evaluate heart function and movement. Question. How does management differ from hypovolemic shock? Answer. In cardiogenic shock, fluids are administered cautiously in small amounts to avoid worsening pulmonary edema, while drugs that increase heart contractility and vasopressors are the main therapies. Question. What is a first-line drug to increase the force of heart contraction? Answer. Dobutamine is a commonly used agent to enhance cardiac contractility. Question. What is the role of a pulmonary artery catheter? Answer. Placement of a pulmonary artery catheter aids in therapy by measuring pressures within the heart and lungs, as well as cardiac output and vascular resistance. Obstructive shock. Question. What is the mechanism of obstructive shock? Answer. Obstructive shock occurs when the pumping function of the heart is impaired by a mechanical blockage to blood flow. Question. What are the three classic causes? Answer. The three classic causes are cardiac tamponade, tension pneumothorax, and massive blockage of the pulmonary artery known as pulmonary embolism. Question. What is Beck's triad for cardiac tamponade? Answer. Beck's triad consists of low blood pressure, distended neck veins, and muffled heart sounds. Question. What is the key finding on focused ultrasound for tamponade? Answer. The key finding is the presence of fluid around the heart and collapse of the right ventricle during diastole. Question. What is the treatment for tamponade? Answer. Urgent removal of fluid from the pericardium or emergency surgical intervention is required. Question. What are the signs of a tension pneumothorax? Answer. Tension pneumothorax presents with difficulty breathing, low blood pressure, deviation of the windpipe, absent breath sounds, and a hyperresonant percussion note. Question. What is the immediate treatment? Answer. The immediate treatment involves needle decompression followed by the placement of a chest tube. Question. What is the classic presentation of a massive pulmonary embolism? Answer. Massive pulmonary embolism presents as sudden collapse, low oxygen levels, clear lungs, and evidence of right heart strain on electrocardiogram or ultrasound. Question. What is the treatment for massive pulmonary embolism causing shock? Answer. Treatment options include medications to dissolve clots or surgical removal of the blockage. Resuscitation and monitoring. Question. What are the goals of resuscitation? Answer. The goals of resuscitation are to restore adequate tissue perfusion, which is reflected by normalization of vital signs, lactate levels, and urine output. Question. What is the target urine output for adequate perfusion? Answer. The target urine output is greater than 0.5 milliliters per kilogram per hour. Question. What is the role of central venous pressure monitoring? Answer. Central venous pressure monitoring has limited value as a predictor of fluid responsiveness, but trends may be more informative than absolute values. Question. What is fluid responsiveness? Answer. Fluid responsiveness is defined as an increase in cardiac output of greater than 10 to 15% following a fluid challenge, such as the administration of 500 milliliters of crystalloid. Question. What is the preferred site for central line placement in shock? Answer. The preferred sites are the internal jugular or femoral veins, as they allow for rapid access. The subclavian vein carries a higher risk of puncturing the lung. Question. What is the role of an arterial line? Answer. An arterial line is valuable for continuous monitoring of blood pressure and frequent blood sampling for gas analysis. Question. What does measurement of central venous oxygen saturation assess? Answer. Central venous oxygen saturation measures the balance between oxygen delivery and consumption. Low values, less than 70%, indicate inadequate oxygen delivery. Question. What is the 3-4-1 rule? Answer. The 3-4-1 rule estimates that for every 1 milliliter of blood lost, 3 milliliters of crystalloid are required for replacement. Question. What are the complications of massive transfusion? Answer. Complications include low calcium levels due to citrate toxicity, high potassium, low body temperature, transfusion-related acute lung injury, and transfusion-associated circulatory overload. Question: why is calcium checked during massive transfusion? Answer: calcium is monitored because citrate in blood products binds calcium, and low levels can impair heart function and blood clotting. Question: what is transfusion-related acute lung injury? Answer: transfusion-related acute lung injury is a serious complication that presents as non-cardiogenic pulmonary edema. Question: what is transfusion-associated circulatory overload? Answer: transfusion-associated circulatory overload is characterized by heart failure and pulmonary edema resulting from excessive volume. Pharmacology question: what is the first-line vasopressor for most types of shock? Answer: norepinephrine is the preferred agent for most shock states as it causes constriction of blood vessels. Question: when is epinephrine used? Answer: epinephrine is used as the primary agent in anaphylactic shock and as a secondary drug in severe septic or cardiogenic shock. Question: what is the effect of dopamine? Answer: dopamine has dose-dependent effects. Low doses were previously thought to benefit the kidneys, while higher doses act on the heart and blood vessels. However, it is now less favored due to the risk of abnormal heart rhythms. Question: what is the role of phenylephrine? Answer: phenylephrine is a pure vasoconstrictor and may be used for temporary blood pressure support but can decrease cardiac output. Question: what is an inotrope? Give an example. Answer: an inotrope is a medication that increases the force of heart contraction. Dobutamine is a common example. Question: what is milrinone? Answer: milrinone is a medication that increases heart contractility and dilates blood vessels, used in cardiogenic shock but may cause low blood pressure. Question: what is the mechanism of vasopressin? Answer: vasopressin acts by causing constriction of blood vessels, and is used to decrease the need for norepinephrine in septic shock. Complications and special situations question: what is abdominal compartment syndrome? Answer: abdominal compartment syndrome occurs when pressure within the abdomen rises above 20 mm of mercury and causes new organ dysfunction, often as a consequence of aggressive fluid therapy. Question: what is the treatment for abdominal compartment syndrome? Answer: the treatment involves emergency surgical decompression of the abdomen. Question: what is reperfusion injury? Answer: reperfusion injury refers to tissue damage that arises when blood supply returns to cells that were previously deprived of oxygen, triggering inflammatory processes. Question: what is multiple organ dysfunction syndrome? Answer: multiple organ dysfunction syndrome is the progressive failure of two or more organ systems following a severe insult, such as prolonged shock. Question: how does shock cause acute kidney injury? Answer: shock can damage the kidneys by reducing blood flow and causing acute tubular necrosis. Question: how does shock cause acute respiratory distress syndrome? Answer: shock can lead to acute respiratory distress syndrome by causing inflammatory injury to the lungs, resulting in non-cardiogenic pulmonary edema. Question: what is the difference between systemic inflammatory response syndrome and sepsis? Answer: systemic inflammatory response syndrome is a generalized inflammatory reaction characterized by certain vital sign changes, while sepsis is systemic inflammatory response syndrome caused by infection. Question: what is refractory shock? Answer: refractory shock is defined as shock that does not respond to initial therapies such as fluids, vasopressors, or elimination of the underlying cause. Question: what is the role of extracorporeal membrane oxygenation in shock? Answer: extracorporeal membrane oxygenation may be considered as a last resort therapy for shock that is unresponsive to standard treatments, especially in severe cardiogenic or obstructive shock. Question: what is adrenal insufficiency in shock? Answer: adrenal insufficiency is the inability to mount an adequate cortisol response, which is suspected when shock fails to improve with usual therapies and diagnosed with a stimulation test. Quickfire and final points question: what is the single most important history in a shock patient? Answer: the most important historical detail is the mechanism of injury or illness, such as trauma, surgery, or recent exposure to illness. Question: what is the most common cause of death in shock? Answer: multiple organ dysfunction syndrome is the leading cause of death in patients suffering from shock. Question: what is the best monitor of resuscitation? Answer: the patient is the best indicator of resuscitation progress. with serial examinations of their mental status and urine output, and measurement of lactate trends as the most reliable objective marker. Question: what is the target hemoglobin in resuscitation? Answer: the target is a hemoglobin concentration greater than 7 to 8 grams per deciliter in most patients, or 9 to 10 grams per deciliter in those with active ischemia. Question: when is a pelvic binder indicated? Answer: a pelvic binder should be applied in any patient with an unstable pelvic fracture and signs of shock to reduce pelvic volume and control bleeding. Question: what is the key to managing hemorrhagic shock? Answer: the key to successful management is to stop the bleeding, as resuscitation will be ineffective if the source is not controlled. Question: what is the role of point-of-care ultrasound in shock? Answer: point-of-care ultrasound, particularly the rapid ultrasound in shock examination, is essential for quickly identifying the underlying cause, such as tamponade, pneumothorax, poor heart contractility, or collapsible inferior vena cava. Question: what is the core principle of advanced trauma life support for any unstable patient? Answer: the core principle is to find and treat the cause of shock during the primary assessment. For patients who are rapidly deteriorating, consider immediately reversible causes such as tension pneumothorax, cardiac tamponade, or uncontrolled bleeding. That's it. Thanks for tuning into today's episode. If you have any questions, leave it in the comment section. If there are any topics you are interested in seeing on this channel, state it in the comment section. If you enjoy the video, remember to like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.